Hi everyone, thank you for joining our presentation. My name is Victoria and my pronouns are she, her. This presentation will focus on best practices for providing screening and diagnostic services such as pap tests and mammograms to LGBTQ clients. This presentation is meant to serve as a guide for best practices when it comes to working with LGBTQ patients and a reference for information that can help you and your staff provide the most inclusive care possible. Our LGBTQ patients share many of the same health concerns as the rest of the population, but they also face a number of significant additional health risks. Research has demonstrated that LGBTQ individuals experience disparities not only in the prevalence of physical and mental health concerns, but also in care due to a variety of factors such as stigma, lack of awareness, and insensitivity. These disparities include less access to insurance and quality health care, including life-saving preventive care, lower overall health status, higher rates of smoking, alcohol, and substance use, higher risk for mental illness, and increased incidence of some cancers like those that EWC helps to screen for. We are going to start by reviewing some key LGBTQ terms and concepts, then discuss how to create a welcoming clinical environment. We will then discuss specific risks and screening protocols for LGBTQ patients, and finally share additional considerations when working with LGBTQ clients. At the end of this presentation, you will also find a series of resources that will expand on what we discussed today with more information and tangible resources to use in your practices. First, let's talk about some key terms and concepts related to LGBTQ individuals. It is important for us to distinguish between sex, gender, sexuality, and gender expression. Gender, or gender identity, refers to a person's internal sense of self. Separately, sex refers to prescribed sex on the basis of genitalia or chromosomes. Sex and gender identity do not always match, so we should not treat them as synonymous. While sex may inform the medical care a client might receive, gender informs the way they see themselves in the world and the way they want the world to see them. Therefore, we do not advise using the terms birth sex or biological sex, but rather sex assigned at birth or assigned sex to refer to this. An example of how you might say this is, he was assigned female at birth. Gender expression refers to the ways in which an individual expresses their gender. This can be done through clothes, makeup, hairstyles, or physical mannerisms. These are choices that an individual makes to affirm their gender identity, and these choices are made by all people. For example, my sex assigned at birth was female, and my gender identity is female as well. I keep my hair long and wear traditionally feminine styles of makeup. There are different versions of the graphic you see here. Some of you may be familiar with the gender-read person instead, but we've chosen the gender unicorn for the purpose of this presentation as it incorporates the aspects of gender identity, expression, sex assignments, and both physical and emotional attractions. This is a brilliant resource. It was created by Trans Students Educational Resources. Notice here that gender identity, gender expression, and physical and emotional attraction exist on a continuum. So a person will fall along the length of an arrow rather than checking off a single box or category. This gender unicorn graphic can be a helpful way to conceptualize how each of these identities exist separately, but come together to form an individual's holistic self-image. For this top section of gender identity, I would put myself completely to the right on the female spectrum and completely to the left for male or other genders. But in the gender expression section, I might put myself 80% toward feminine and 20% toward masculine expression, because I may express myself and dress feminine today and less feminine tomorrow, as I often wear more masculine clothing. The final term that we are going to define is sexuality or sexual orientation. This is an umbrella term classifying one's attraction towards others. For example, gay, straight, bisexual, pansexual, queer, or asexual, among others. On the gender unicorn, it is separated out into physical attraction and emotional attraction. And in doing so, you can see that an individual's physical attraction to another is not dependent on their gender identity, expression, and sexual orientation. For example, a trans person can be gay, straight, bisexual, pansexual, queer, or asexual. Similarly, an individual's emotional attraction to others is not dependent on or necessarily related to their gender expression or sexual orientation. Someone can be bisexual but emotionally attracted to people of the opposite sex only. There are other relevant terms that can help us to describe the interaction between the identities we spoke about in the last slide, specifically the relationship between sex and gender. Transgender, or trans, is an adjective that describes a person who does not identify with the sex they were assigned at birth. Inserting the article a before transgender or adding ed at the end is not only grammatically incorrect, but also implies something happens to make someone the way that they are, which is not true. Please also note the correct spelling of trans man and trans woman. Though the omission of a space may seem insignificant, it is important. A non-binary person is someone who identifies outside the gender binary as neither male nor female, regardless of their sex assigned at birth. There is no one way to be non-binary. Non-binary people may use the pronouns they, them, theirs, but not all do. We can use the phrase trans, gender nonconforming, and non-binary, or TGNCNB, as an umbrella term for all individuals who identify outside the gender binary. It is important to note here, though, that some trans folks want to be seen in the gender binary, and identifying as a man or woman can be really affirming. Some people may prefer the terms transmasculine or transfeminine depending on their gender expression. Because everyone's identity, expression, and preferences vary, it's important to allow people to self-describe. It's also helpful to familiarize yourself with local terminology and approach patients with humility when determining which specific terms to use. Each patient or client should be approached as an individual with no preconceptions. Meeting patients where they are without judgment will enhance the patient-provider relationship and avoid the perception of stigma or pathologization. During exams, use the same language that a patient does to describe themselves, their sexual partners, relationships, and identities. It's also okay to ask the patient to clarify any terms or behaviors with which you are unfamiliar, or repeat a patient's term with your own understanding of its meaning to make sure you have no miscommunication. However, it should not be routinely expected that patients teach their providers, and providers should limit historical questions to those that are relevant to the current visit or problem. Often, people make assumptions about the gender of another person based on one's appearance or name, but this type of assumption can be wrong, and worse, it can be harmful. Using someone's correct pronouns shows respect and creates a more inclusive environment. In English, the most common pronouns, he or she, specifically refer to a person's gender. For queer, gender nonconforming, non-binary, and transgender people, these pronouns may not fit, they can create discomfort, or they can cause stress and anxiety. Here, you see a few examples of other pronouns and how they would be used in practice. Some people prefer they, them, some people use neopronouns like sie, zer, and some people don't like any pronouns used for them at all. In this case, just use your name each time you refer to them. Misgendering is mistaking or assuming people's pronouns without asking first. Asking and correctly using someone's pronouns is one of the most basic ways to show your respect for their gender identity. When you misgender someone unknowingly, the impact is more powerful than the intent. If you make a mistake, apologize and move on. Don't belabor the apology. So, how do we know someone's pronouns? That's simple. We have to ask. And when we ask, we should not ask what pronoun someone prefers, uses, likes, or goes by. People have pronouns. So I can say, "Hi, my name is Victoria and my pronouns are she, her. How about you?" When calling a patient's name from the waiting room, use the name they've provided on their intake forms or use their first initial and last name. Next, we'll move on to discuss how clinical environments can be made more comfortable and welcoming for LGBTQ+ clients. Cultural humility is at the core of these recommendations. Cultural humility is a concept through which individuals recognize that their own experiences or identities may not project onto the experiences or identities of others. All staff, including front desk staff, nursing staff, etc., should be provided with training on LGBTQ+ health issues, and this training should be integrated into the standard hiring and onboarding process for all employees. Updated intake forms can be a very explicit way to make the clinical experience more inclusive right off the bat. Intake forms should allow patients to include their chosen name, chosen pronouns, and current gender identity in addition to the sex listed on their original birth certificate. If intake forms are completed online, patients should be able to select multiple options for each question. These options may be framed with a statement like the one italicized here, which articulates why these questions are being asked with the given options and presents the choice to decline to answer instead. Intake forms may use the term relationship status instead of marital status and include options like partnered. When asking, on the intake form or verbally, about a patient's significant other, use terms such as partner in addition to spouse and/or husband or wife. Expanded options for sexual partners and sexual orientations can also enable you to better identify a client's specific healthcare needs. Waiting areas should include materials that signal a commitment to serving the LGBTQ+ community. You can display pride flags, LGBTQ+ friendly symbols or stickers, or posters from nonprofit LGBTQ+ advocacy organizations. You can also visibly post a non-discrimination statement or display brochures and educational materials, multilingual when possible and appropriate, about LGBTQ plus health concerns such as breast cancer, safe sex, hormone therapy, mental health, substance use, and STIs. Examples of these items can be found in the resource pages at the end of this presentation. Bathroom policies should define all bathrooms as gender neutral or specifically state that patients may choose either the women's or men's rooms based on personal preference. In the latter case, having at least one gender neutral bathroom available will provide a safe space for non binary people or those in transition who feel uncomfortable in gendered spaces. In the next section of this presentation, we'll be discussing specific breast health considerations for LGBTQ patients. We refer to cancer in breast tissue as breast cancer and to the tissue itself as breasts. That said, we recognize that some LGBTQ folks do not identify as having breasts, feel ambivalent about having breasts, or perhaps prefer the term chest. First, we'll discuss specific breast and chest health considerations for lesbian, bisexual, and queer women. As a general rule, if an individual has a particular body part or organ or otherwise meets criteria for screening based on risk factors or symptoms, screening should proceed regardless of gender identity, sexuality, etc. Lesbian, bisexual, and queer women should receive mammograms on the same age-appropriate screening schedule as heterosexual women. Gender variant or butch women may especially avoid mammograms. Because delayed detection and diagnosis are associated with poorer outcomes, it is important to ensure that all women in your practice are aware of the need, feel comfortable receiving mammograms, and do receive the screening. Null gravidity, low parity, increased adipose tissue, tobacco use, and less frequent use of oral contraceptives are more common in lesbians than among heterosexual women. These risk factors are associated with breast cancer, but more research is needed to determine actual differences in prevalence rates of breast cancer. General recommendations for mammography and breast health screenings, therefore, should be followed for all lesbian, bisexual, and queer patients. Let's talk next about breast health for trans women. In trans women, factors that may contribute to a reduced risk of breast cancer include potentially less lifetime exposure to estrogen and, in some cases, the absence of or minimal exposure to progesterone. However, trans women have a high prevalence of dense breasts, which is an independent risk factor for breast cancer and also a predictor of increased rates of false negative mammograms. If a trans woman has been taking estrogen for 5 years or longer, annual mammograms are recommended beginning at age 50. Providers and patients should engage in discussions that include an assessment of individual risk factors. Trans women are often concerned with their breast appearance and development and may perform frequent self-examinations. Patients may request breast exams for symptoms of early breast development like pain, tenderness, and nodularity, and may find breast examinations to be gender-affirming. Next, we'll discuss breast and chest health for trans men and non-binary patients. Trans men and non-binary patients who have not undergone top surgery or who have only undergone chest reduction should receive annual mammograms beginning at age 40. Chest surgeries for trans men and non-binary patients are more commonly referred to as top surgery, and patients may have different amounts of chest tissue remaining depending on their desired chest contour. It is important to obtain a clear surgical history and to ask patients to clarify when necessary, as some patients may have undergone only breast reduction. Clinicians should engage in dialogue with patients who have undergone bilateral mastectomy about the unknown risks associated with residual breast tissue, as well as the possible technical limitations of mammography. Annual chest exams are recommended for those who have had chest surgeries, and patients should understand the need to identify changes to their body and what is normal for them. Another important chest health topic for trans men and non-binary patients is binding practices. Binding involves the use of tight-fitting sports bras, shirts, ace bandages, or specially made garments to provide a flat chest contour. Binding of the chest to create a masculine appearance may lead to skin breakdown or other complications of the skin, and patients may be hesitant to remove the binder for a physical exam. Appropriate and sensitive history taking and education about safe binding is recommended for all trans men and non-binary patients. In our next section, we will discuss cervical cancer risks and screening procedures for LGBTQ clients. First, let's discuss cervical health for lesbian, bisexual, and queer women. Lesbian, bisexual, and queer women are as likely as heterosexual women to develop cervical cancer, and yet are up to 10 times less likely to undergo regular screening. The human papillomavirus, or HPV, can be transmitted among women who exclusively have sex with women. Specific to cervical cancer screening, sexual minority women are less likely to have had a recent routine pelvic exam, perhaps due to reduced demand for birth control and therefore lower utilization of routine gynecological care. Lesbian, bisexual, and queer women are not mentioned specifically in any of the major national guidelines for cancer screening. Although sexual minority women fall under the banner of all women, not all providers are following screening guidelines with lesbian and bisexual patients under the mistaken assumption that recent sex with a man is the only way to transmit HPV. On the next slide, we'll discuss cervical cancer risks and screening for trans women. There are several techniques and approaches used to create a neovagina or neocervix, also referred to as bottom surgery, all of which have the potential to develop malignancy. The use of genital skin flaps presents the risk of squamous cell carcinoma, and the use of intestinal tissues presents the risk of adenocarcinomas. Several exposures may influence the development of malignancies in this tissue, including skin irritants, semen, and HPV infections. Screening should include an annual postoperative physical exam, including a PAP and/or HPV test every 3 to 5 years beginning at age 21. HPV vaccination is also recommended for our transgender patients. Next, we'll discuss cervical health and screening for trans men and non-binary patients. Trans men and non-binary patients are still at risk for cervical cancer, but obtaining a PAP or HPV test may be challenging for them. Inadequate screening for cervical cancer is linked to the barriers transgender individuals face in accessing culturally sensitive healthcare. Cervical cancer screening for trans men, including interval of screening and age to begin and end screening, follows recommendations for cisgender women as endorsed by the American Cancer Society, U.S. Preventive Services Task Force, and the World Health Organization. Trans men under the age of 21 should not have Pap tests regardless of their age of sexual debut. Pelvic exams may be traumatic and anxiety-inducing procedures for trans, gender nonconforming, non-binary, and other trans-masculine people. A painful Pap test experience is correlated with non-adherence to future screening and colposcopy. Should the individual express distrust or concern about the examination, it may need to be deferred until a later date once a trusting relationship has been developed. Various techniques can be used to make a pelvic exam less uncomfortable. Discuss procedures with the patient beforehand, including the order in which steps will occur. Allow time for the patient to express any concerns prior to beginning the exam. Allow the patient to have a support person in the room, listen to music on headphones, or utilize other strategies to provide distraction during the exam. Explain each step in a clear, direct way throughout the exam, such as saying, "You will hear the clicking noise of the speculum now," or "You will experience some pressure next," and remind the patient that the exam can be stopped at any time at their request. Some patients may have difficulty verbalizing their discomfort during the exam, so allow for nonverbal signals like snapping or tapping the side of the exam table to communicate a need for pause or stop. You may also offer the use of a mirror to allow the patient to directly observe the exam. Another option may be to allow patients to conduct their own self-swab for a Pap test and move to a speculum exam only if necessary. Patients can be instructed on how to insert the swab and collect a specimen, and this can feel much less invasive than a traditional speculum exam. When conducting a speculum exam, it is best to begin with the smallest speculum possible to minimize discomfort. However, avoid taking out the speculum and reinserting a new one. Repeated penetration can be very triggering. Lastly, the terms vagina, vulva, or other traditionally gendered anatomical terms may be uncomfortable for trans men and non-binary patients, so consider using the phrase front genital hole instead. In this last section, we'll discuss additional considerations when serving our LGBTQ+ patients. It is important to understand that the LGBTQ+ community is particularly vulnerable to social stressors that lead to increased tobacco and substance use. Social stress may also contribute to body image, exercise, and eating habits. Be prepared to intervene and provide treatment options. If a female patient identifies as lesbian or indicates a female sexual partner, do not assume that she has never had a male sexual partner, has no children, has never been pregnant, or has little to no risk of STIs. If a male patient identifies as gay or bisexual or identifies a male sexual partner, do not assume that the patient has never had a female sexual partner or has no children. Do not make assumptions about past, current, and future sexual behavior. In order to gather the most accurate sexual history possible and to provide the best counsel, phrases like partners that produce sperm may better capture the specific reproductive needs of each patient. Patients with a uterus who take testosterone should also be advised that testosterone does not serve as birth control, so other contraceptive measures should be taken to prevent pregnancy if they have partners that produce sperm. Conduct violence screenings during appointments. LGBTQ+ people are often targets of harassment and violence, and LGBTQ+ people are not exempt from intimate partner or domestic violence. Individuals being battered may fear being outed. Assure the patient of confidentiality to the extent possible. Screening questions should be asked in a gender-neutral way. For example, have you been hurt by someone you are close to or involved with, or by a stranger? Are you currently being hurt by someone you are close to or involved with? Have you ever experienced violence or abuse? Have you ever been sexually assaulted or raped? Trans people are sometimes subject to the most extreme levels of social exclusion. This can destabilize individuals and create a host of adverse health outcomes. Health interventions will need to consider the aggregate impact of health risks resulting from this stigma. Regardless of whether a trans person is visibly gender variant, they may experience trauma, increased stress, and direct grief as a result of violence against other community members. In these last two slides, you'll find resources that expand on what we've discussed today and provide materials that you can use in your own practice. We have resources on collecting demographic data from patients, making your clinical space feel more welcoming and inclusive, and more information on LGBTQ+ health more generally. Feel free to revisit these slides